Okay, we're recording now, David.
All right. Yes, good morning, or should I say good afternoon? I know it's about 2 p.m. out there in Chicago. Professor Lenny Jason, professor at Depaul University, director at the Center for Community Research. It's a pleasure to have you on. This is my first time interviewing a health professional, and it'll be a great learning experience, not only for myself, but for others as well. So yeah, Lenny, can you tell us a little bit about the work you've been doing recently with the long COVID research?
Well, we believe there's lots of similarities to the illness called Mecfs. Some patients refer to it as ME, myalgic encephalomyelitis. Most patients do not prefer the term CFS, the acronym CFS, which stands for chronic fatigue syndrome. But Mecfs, if we use that term, is something that basically involves people who've had 6 or more months of a variety of conditions. The Canadian criteria specifies some of them as like post-exertional malaise, unrefreshing sleep, cognitive impairment, and other things like that. The Institute of Medicine in 2015 came up with symptoms as well. So we do have a disorder, and we have a couple different case definitions. And it's important probably to come up with a consensus on one of those case definitions. But in any event, we do have a syndrome, and the COVID-19 is probably a little bit more specific in that we know that a virus attacked the person and the person has not recovered. With Mecfs, you have many more people who have different routes in to the particular illness. The Epstein-Barr Virus seems to be, which causes mono, seems to be one of the primary ways of us trying to understand who has particular trigger and then doesn't recover from it. It seems that almost 10% of people who get mono, which is caused by the Epstein-Barr virus, seem to have difficulty recovering 6 months later. With COVID-19, it looks like it might be 10-20% of people seem to have lingering symptoms that are serious. When you think about mild symptoms, it's probably a much higher percentage of the COVID-19. So each of the groups, Mecfs and COVID-19, have some type of trigger. And then they basically have 6 or more months of illness, and a variety of different symptoms occur. And certainly it's very debilitating for both groups. So I've been interested in looking at the Mecfs group versus the COVID group and trying to differentiate them. It does seem like the COVID group initially has higher immune markers, sore throats, flu-like symptoms. They tend to begin to decrease over the 6 months. The Mecfs group has already had that attack of something. And when we interview them, they've already been sick for several years. So their immune markers tend to be a little bit lower. The striking thing about the COVID group is that the neuroendocrine, neurocognitive actually symptoms, the cognitive issues seem to be the one area where actually symptoms over time for COVID group get worse. So people have more difficulties processing information, and that does seem to be something that is different. Still, the Mecfs group has very significant symptoms in all the areas, and the COVID group, generally, many of them have some improvement, but a very high percentage of the group that we interviewed had very moderate or serious problems in terms of not being able to resume their prior lifestyle. So if you think about 35 million people probably have had this COVID. The estimate probably might be 2 or even 3 times higher. And if you think
Yes.
about 10% of them not being able to recover, then you're talking about maybe 3 or 4 million people that might be in this category. And so the long haulers are literally millions. And yet the MECFS are probably closer to 1.5 million. So the long haulers are going to be many more than has been documented in terms of MECFS. So in terms of prevalence, long haulers are probably going to be a higher percentage of people, a higher number of people in the United States. In terms of symptoms, they all have very common symptoms, but there's some that are a little bit more unique. Taste and smell and things like that seem to be altered, seem to be a little bit more unique to the long haulers. So that's what some of the research we have done has found. We're currently in the process of looking at a group of over 4,000 college students who we have blood samples on, as well as self-report data on, and we're following them over time. Certain percentage of them got mono, and we're sort of seeing those that recovered versus not. And we're also testing the group in terms of those who got COVID-19. So we have data from when they were well, and we'll be able to use that data to predict what might have caused some of them to be attacked by this virus and not get well.
Okay. Yes. Excuse me. Yeah, one of my fellow peers actually brought up the question to you, Lenny, from your observations. Is long COVID going to be similar to MECFS, or is it too early to tell? Do we not have enough longitudinal studies?
Well, I think that MECFS is caused by many different types of insults, viruses, other things too. And that people then seem to go into this very debilitating state. And there's actually some percentage of people who get MECFS where it's more of a slow onset and it's hard to find what triggered it. But certainly when we look at the symptoms of those who have 6 months later after COVID-19 and several years later with the MECFS, we see very common symptoms of sleep difficulties, cognitive difficulties, fatigue, post-exertional malaise. These things are very common in both groups. The other thing that's common in both groups is that if you don't have something biological that you can show a doctor and say, here's a cardiac problem, or here's a circulatory problem, or here's some problem with my lungs. And if you don't have that, which is what the MECFS group has had difficulty in having, like a biological biomarker, which it's called, or some specific impairment that they can say is caused by the MECFS, then they have a lot of skepticism. So this is one thing that the long haulers, if they have something that's very specific, that's been damaged, they'll basically probably get a better reception from the healthcare workers. If they don't have something that they can point to causing their continued symptoms, they'll probably end up with a similar situation that the MECFS group has had for decades, which is people doubting the legitimacy of their illness. So not only did they get a debilitating illness, and they have basically have to deal with the crisis of that, as well as the trauma, but then they get re-traumatized by the healthcare reaction to their illness and the delegitimization. And I think that will be common also to the long haulers. And that's why it's so important for the long haulers. And literally there's going to be millions of them to get together and really with the MECFS groups to basically try to stand up for the need for services, the need for research, and the need for people to take it seriously.
Very well. One thing I was curious about, Lenny, is with regards to case definitions. Now, I think you mentioned that case definitions are particularly important in relation to public policy. Can you talk a little bit about that?
Yes, if you look at the hundreds of diseases that the NIH studies, you know, ME/CFS is probably just about the only one that I know of that doesn't have a consensus on a case definition. And why is that important? Well, if different people are using different variations, some using Fukuda, which was developed in 1994, some using the IOM, which was developed in 2015, some using Canadian, which was developed in 2003. There's actually 20 different case definitions. And there's NICE guidelines, which are also going to have theirs. So if everyone is using slightly different criteria to select patients, you know, you could sort of say, well, they're all getting about the same people, but that might not necessarily be the case. And if you have different patients in different cohorts and different laboratories, then it becomes much harder to understand, you know, what is the biological markers that differentiate those groups.
Yes.
So you really want to have homogeneous patients across settings, across the world. And that has not occurred. And that has been a major detriment to us basically moving forward. So I would say, from my perspective, there's probably nothing more important in terms of a priority for patients, the scientific community, and government officials to come together and to basically say, this is a clinical case definition, this is a research case definition, and let's all use it. And that would be an enormous contribution. And it's been something that I have been arguing for a long time. And I think it's something that the field needs to see as a priority. And I think part of the reason that they don't is that they say, well, why don't we just wait longer until we have a biological marker? Well, that didn't stop other illness groups from coming up with a case definition and having a consensus. And I don't think that should be a reason why we shouldn't do it for our field as well.
Yes. One idea that came to mind, perhaps the connection between case definitions and problems with ICD-10 coding. Some of these codes fail to differentiate between individuals who have post-exertional malaise and do not have post-exertional malaise. Do you think ICD-10 coding, sort of revising that and reforming that, trying to fix that problem, is useful?
Yeah, and there's an effort to do that now. And, you know, you'll see chronic fatigue syndrome, you'll see myalgic encephalomyelitis, post-viral infection. So there's a lot of different terms that are used. And yes, to the extent we had a case definition that could apply, you know, it's really not a difficult enterprise. And I'll tell you how simple it is to kind of solve it. And if we can solve it for ME/CFS, we can solve the same problem for the long haulers. It's real simple. What you basically do is you say, okay, if you have 6 or more months of fatigue or 6 or more months of symptoms, you have chronic fatigue. And that will affect something like 5% of the population, 4 to 5% of the population. Millions of people have chronic fatigue. If it's more serious and you have lots of symptoms that go along with it, then you have, we'll call it chronic fatigue syndrome. And we could use the Fukuda criteria to describe that group. If you basically have very specific symptoms, not just general ones, and you say it has to have very things like post-exertional malaise, memory impairment, as well as unrefreshing sleep, and we call it ME/CFS. And that can be defined by the Institute of Medicine criteria. And then if you want a more severe group, you could basically say, we'll tear out the ME people, myalgic encephalomyelitis, and we'll define them by the Canadian criteria or the ME/ICC. So there's a system that's set up. It's not hard to do, where you could basically have the clinical criteria be the FACUDA and the IOM, because the IOM does not have any really disorders that it doesn't affect. I mean, there's nothing exclusionary, whereas the CCC and the MEICC has lots of exclusionary. So if you have cancer fatigue, you could say, okay, you have the IOM, or if you have MS fatigue, you can also have the IOM, or if you have melancholic depression fatigue, you could also be IOM. But the CCC and MEICC are more rigid with exclusionary criteria. So we could have a clinical case definition and we can have a research case definition. The IOM being the clinical, the CCC or MEICC as being the research. Problem solved. Then we have criteria, and then we can have questionnaires developed to tap those criteria, and we can have people using similar criteria and then cutoff points for the symptoms. This is how science moves. And if you miss this important piece of the scientific endeavor, then it's like a house of cards. Your bottom layer is basically whether you have it or don't have it. Does it meet the clinical or research case definition? If you fail in this task, then everything you build on that layer of house of cards is shaky. And that involves prevalence, how many people have it, biological markers, treatment, and on and on. So that's why it's so critically important to have a case definition.
Yes.
And I might add, for COVID-19, the case definition is just as important. And I would say that there is a group, the World Health Organization, that is trying to come up with a case definition now. I think it's not a difficult thing. And I can tell you right now how you could define it. And you could basically start out with having a case definition which is, what's the cause? Is it the Delta variation of COVID-19? Okay, that's the cause. How many months have you had it? Has it been 3 months, 5 months, 7 months? Number 3, what biological areas has it interrupted? Do you have heart disease? Do you have lung problems? Do you have brain issue? So that you could basically say, what are the medical problems that are caused? And, and then you say, is it mild? Is it moderate? Or is it severe? And those who have mild basically don't have any CFS. Those who have moderate and severe, a higher percentage of them would meet one of these ME/CFS or ME case definitions. And that means that you've had the symptoms for 6 months, and now you meet ME/CFS or ME criteria. Problem solved. That's it. It's as simple as that. And here you have hundreds of people around the world scrambling, trying to figure this out when it is so simple. And it basically could be taken care of today.
Great. One of the things I was curious about, Lenny, is you've talked about the Depaul Questionnaire. Can you talk a little bit about it, and if you think it would be applicable to long COVID?
Yes. So we had about 280 people with long COVID fill out our Depaul Symptom Questionnaire, which has 54 items. We added several items that are more specific to COVID-19, like, for example, loss of hair. And we basically gave it to these individuals and compared people with ME/CFS to long haulers. Now, I might add that this questionnaire has been developed over a 10-year period of time. It has psychometric positive characteristics of predictive validity. It has concurrent validity. It has convergent validity. So it's been well validated. And it has actually been used with other groups like MS, multiple sclerosis, and post-polio syndrome. So we've been able to differentiate those conditions as well with these questions. So one of the reasons the questions are important is that, David, if you asked somebody, do you have fatigue, or do you have post-exertional malaise, or do you have memory problems? Well, a physician in their office is going to say it 1,000 different ways. And the answers are going to be determined by how you ask the question. So if you basically say to a person, what's your frequency of fatigue? How frequent do you have it? That question does not differentiate individuals who have depression versus those who have ME/CFS. But if you ask the question, not only how frequency, but how severe is it, then you can differentiate major depressive disorder from ME/CFS. So the way you ask the questions is so important so that you can ask them the same way to different people in different settings.
Yes.
I might add that there are about 12, 14 countries right now that are using this questionnaire. They're using it for ME/CFS. They're using it for long haulers, and it's very exciting. Not only do we have a 54-item questionnaire, we have one that's just 14 items, short form. So it can be done very quickly, and it can also, once you give it, you can then decide which case definitions do people meet. We also have a longer version. It's called Depaul Symptom Questionnaire 2. It's a little bit more items. And we also have basically one that just focuses on post-exertional malaise. We have one for adolescents as well and youth. So we have all these questionnaires that have been developed. We offer them free to anybody who wants to use them. And we continue to work on them. And I think that they're an important part of the scientific endeavor. The scientific endeavor involves first deciding which symptoms should be assembled to categorize an illness. Well, that's what a case definition tries to do. It basically says these symptoms are the things that we should basically be focused on. And that's important. I think in the history of ME/CFS, we've gotten that step wrong multiple times. You know, the Fukuda 1994 criteria had a polythetic criteria where you pick 4 out of 8. Well, if you pick 4 out of 8 symptoms and you miss the important ones that should be core symptoms, you're missing the important people that should be brought into the criteria in the case ascertainment effort. So bottom line is, yes, you need a good questionnaire. You got to ask questions in a standardized way. And if you do that and you use a good, you can basically help develop, number 1, the symptoms. Number 2, how do you assess them with a questionnaire? And number 3, setting up criteria for deciding when a symptom is severe enough to count. So if it basically has a symptom a little of the time and basically it's kind of mild severity, does that count? Well, that's where you need consensus. You have to decide what point does a symptom's frequency and severity count? And that's basic research that has been done, can be done on questionnaires. And if you do that right, you can basically solve this diagnostic case definition problem once and for all. And this is something that our field has not done. And it's at the detriment to every patient and to all the scientists for us not tackling this problem.
Very well. Lenny, with regards to the case definitions, I know from 2013 to 2019, you did some studies on CFS infections with mono, as well as 2019 to 2021 incidents of ME/CFS following mono. Did that anyway have any effect on how you viewed case definitions?
Well, it's important to do prospective research. And really the best way of finding out, why certain people who have a trigger, whether it's long haulers or whether it's ME/CFS, the trigger can be COVID-19, it could be a virus, could be a bacteria, whatever it is. You don't know why some people have that trigger and get over it. And then other people have that trigger and then are ill and don't get over it. And there's probably significant differences between those two groups. But after they're sick, their body changes. And it's harder to kind of come up with a solution to this mystery of why certain people seem to get ill and don't recover. Some people get ill and do recover. And what you really need is data before they got sick. You really want to look at their biology, their immune system, their functioning. And then you can basically say, what is it among them that makes some of them predisposed toward not recovering when some type of viral insult or some other thing occurs? So a prospective longitudinal study that gets people before they get ill is critical.
Yes.
And our study is one of the really only ones that has tried to do this. And that's why it's so important, because we can look at baseline characteristics and we can basically begin to identify problems in their baseline characteristics that might predispose them toward not recovering from a viral insult.
Yes. Very well. Lenny, I was curious. I know you've done some work in violence prevention, smoking cessation, as well as recovery homes. And perhaps in these type of areas, cognitive behavioral therapy may be useful. Can you explain to the viewers why an Mecfs, CBT can be harmful?
Sure. So I am a psychologist. I was trained in clinical methods and clinical therapies. So I have a pretty good understanding of what these different systems do. So if you give somebody cognitive behavior therapy who has cancer, you basically are helping them cope with the illness. You're not trying to cure them. The problem with cognitive behavior therapy, when it was applied to patients with Mecfs, it was in the 1990s and 2000 advertised as the cure. So basically it said, if you basically use these particular techniques, you are going to get cured. And patients, whether they have Mecfs or cancer or MS or any other health condition, would probably resent, being said that, because they would not say that this is true. Now, cognitive behavior therapy actually does work extremely well for a number of psychiatric conditions. So for example, if you have depression and you basically have cognitive behavior therapy, it's about as effective as anything, because it's basically helping people change the way they think and how they talk to themselves and how they behave. So, but if it turns out that the composition of the groups that you're working with have lots of people who are within it who have more depression reasons for their symptoms, and you call them having Mecfs, and then you use those particular techniques and you get a number of them that get well, then you could sort of say, well, if cognitive behavior therapy works with these people, why can't it work with everyone? Well, it probably is working extremely well with those who have primarily psychiatric reasons for their condition. If you have melancholic depression or major depressive disorders solely, those people are going to do fine. You tell them to go out to the gym and work out and become more active, they feel better. Person with Mecfs, tell them to go to the gym and work out 3 times a week for a half hour. They're going to end up with post-exertional malaise. So yes, there was a problem with how cognitive behavior therapy has been used and the promises that were made about what it could do. And actually, it ended up stirring up a lot of problems, particularly for the patients who then kind of went to offices and their primary care physicians said to them, well, gee, cognitive behavior therapy works. Why don't you do it? And if the person tried it and felt bad, it didn't improve and got worse, the primary care physician would probably say, there it is, self-defeating behavior again, it's your problem. And that doesn't help patients.
Right. And part of the problem with some of these studies that have supported attempted to support CBT and graded exercise therapy is has to do with the case definitions and some of the individuals not having MECFS?
Everything comes back to the case definition. And that is why I've been harping on it, if you can believe it, for almost 3 decades. And, you know, I've basically said multiple times that we have to solve this problem, because if you get the diagnosis wrong, you're going to have incredible consequences. So let me give you an example. Let's go back to depression. Depression is, after substance use disorders, about the most important illness in terms of the prevalence. It's very prevalent disorder. So there's a lot of people who go to primary care physicians with a major depressive or a anxiety disorder. So if you talk to a person who has a primary depressive disorder and you say to them, well, if you exercise, do you feel better? And they'll say, yeah, when I get active, I feel a little bit better. They say, if you ask them, if you were well tomorrow, what would you do? They'd say, I don't know. They have what's called anhedonia. So for
Yes.
they have a condition that's specific. But let's take this, and that person might have memory problems, might have sleep difficulties, might have joint aches, might have fatigue. So again, easy to misclassify them as having MECFS. Now let's take a person with MECFS who's accurately diagnosed. You basically say to them, what happens when you do too much? I feel sick, post-exertional malaise. Classic.
Yes.
What happens if you were well tomorrow? What would you do? They would give you a list of 10 things they'd want to start getting back to. They have no problem wanting to get back into life. So I'm just saying, we're talking about 2 totally different pathways. And that's why the diagnosis becomes so important.
Yes, absolutely. Lenny, within the realms of community health and these questionnaires that you've done and some of the stuff you've talked about differentiating between melancholy and MECFS, is there any way patients or advocates can get physicians to follow some of these models?
Well, I think what's needed, which has not occurred, unfortunately, is that when scientists have gotten together, myself included, we've tended to overcomplicate things and put together position statements and manuals that most primary care physicians and nurses, you know, basically aren't going to become experts in this area. It'd be nice if we could train more of them, if we had treatment settings where they could learn this stuff. But the reality is the garden variety healthcare workers need something brief. And what's needed is a brief questionnaire that you could give somebody. They could fill it out in 2 minutes, and then it could spit out, we think this person has all the symptoms of chronic fatigue syndrome, MECFS or ME. Very simple. And we actually have the questionnaire developed. It's our short form of the Depaul Symptom Questionnaire. We are thinking about trying to kind of make it available, where basically you could put it into any computer and it could basically, person could just type in their symptoms and it would spit out for the primary care healthcare worker an initial screen. Now that could be followed up with more comprehensive testing, certainly, but that's what you want. You want an initial screen. We are working on that. And we think that if we could get something like that out to, you know, lots of people, at least the diagnostic challenge would be reduced. So that is something that is important. We're committed to that. You know, the problem, of course, is, you know, we want to do 1,000 things. And as you know, you got to be somewhat focused. But we do think kind of case definitions, diagnostics, and tools for healthcare workers is of most importance. And we're going to work on it on our spare time to make sure we get this stuff done.
Yes. I mean, one of the things that you've talked about is the importance of media interventions. You mentioned that mass media are ideal for conveying positive health promoting messages. I really appreciate the fact that I think you went on local news in Chicago, WGN, a couple months ago and talked about the impacts of long COVID. I really do appreciate that. And I'm curious, what efforts can peers and advocacy groups make to encourage the growth of community psychology?
So just remember, we're all connected, what do they say, by 7 people with just about everybody on the planet. So if we think about our social networks, we might not know a reporter ourselves, but we probably know somebody who does know a reporter. We might not know a legislator ourselves, but we probably know someone who knows a legislator. If we could use our social networks and the power of so many thousands of people who are sick to basically leverage our voice. The reality is Frontline has never done a segment on MECFS. 60 Minutes did a piece over the last month for a patient who kind of talked about, you know, I think the nightly news did a piece. But has there been attention to a disorder that affects hundreds of thousands of people? It's a disgrace. You know, again, you know, we have been unappreciated by the media. And I think we have to stop that. And I think we've been unappreciated by many groups. And I think
Yes.
that we have to make our voice known. And I've written blogs, I've written editorials, I've written op-eds. You know, I've basically done what I can to basically talk to media. But I can tell you that, you know, it's a very small amount of space that we put into the cyberspace. And I think we need to do more. And particularly with long COVID getting so much attention these days, this is an ideal opportunity to link in with our colleagues who are affected by that virus, and to together really mandate and require these individuals to give more attention. Jen Bria has done a really nice job with ME Action, as you probably know, in terms of getting the word out. But it just needs to be so much more.
Yes. And I'm glad that your colleague Art Myron, in his rebuttal to this CDC systematic review, pointed out the problems with the Oxford criteria. And I think that's a great thing.
Yeah, I mean, again, it's one classification. If you basically say you've had 6 months of fatigue, and that's the primary criteria, that affects almost 1 out of 20 people. It's a lot of people. And if you walk up to 4 people and say, who's fatigued? One of them will say they're fatigued. 25% of the population is fatigued at any one time. 4 to 5% are fatigued for 6 months. So this is very common in the population. And that's part of the problem, because most people, if you walk up to them and you say that you have MECFS, they'll say they do too, but they don't.
Right. And Lenny, do you feel part of that maybe due to the generalization of the chronic fatigue label? Some individuals have mentioned that perhaps it may be better to just use the term myalgic encephalomyelitis. What do you think about that?
Yeah, exactly what I think needs to occur, that you have people who have chronic fatigue, and that's it. The fatigue is their primary symptom. There's a group that has, I think, MECFS, and we'll call them basically those who meet the IOM criteria, and with very few limitations, restrictions. So that's
Mhm.
basically MECFS, which is transition term. And then I would say we have a group of people who meet ME, myalgic
Yeah.
encephalomyelitis. And those are the ones who you really focus on, from that 4 to 5%, you're down to a very sliver of people who have ME, because most of them have what's called chronic fatigue. So the reality is, what you want to do is really get the ones who have this illness, and then you can make incredible progress forward.
Yeah.
But the differential diagnosis of terms and definitions is critical. Chronic fatigue, MECFS, ME. Perfect. That's it. That basically solves the problem.
Right. Lenny, I'm sure you're aware that organizations like ME Action and Solve ME have done a lot of great things. With that being said, do you see yourself like sort of like a third eye, an outsider looking in? Do you see any potential weaknesses or rooms for improvement that can be made?
So yeah, I'm kind of a gadfly. I guess I sort of I did not participate in the Canadian criteria, the MEICC criteria, the Fukuda criteria. So I mean, I basically, my area is diagnosis. So you would think that someone would want me on one of those groups to kind of help develop some of those criteria, since that's my specialization and I know something about these things. But that's okay. I've done probably more basic research on case definitions than just about anybody. And I publish paper after paper after paper that basically
Yes.
tries to tell the truth. And if I can tell the truth to you, David, I'm a happy man.
Yes.
Because I'm doing what I basically am here to do, which is try to help understand complicated systems. I am what's called a community psychologist. And you mentioned all the different areas that I work in. Yes, I do work in those different areas, but I'm interested in how systems operate and when systems don't work. And that's what I have a particular expertise on, of trying to go into complicated systems and trying to say, this is what's not working. And this area, for a person who's interested in that, is perfect, because there's so many systems that are totally dysfunctional in this area that I can have a field day for my entire career. Now, doesn't mean it's a good thing, but intellectually, I can basically feel very satisfied with my work if there's one person that I can basically influence. And that's it. And that one person is me. If I feel good about what I'm doing, that's great. If I can't change anything, I've given it my best, and that's good enough.
Yes. Lenny, I'm sure you remember in the early 2000s in your home state of Illinois, President Obama sort of revolutionized the grassroots movement and really changed the way community organizing politics worked. Is there anything that we can learn from that and apply it to MECFS advocacy?
Absolutely. Yeah, I think he has brought to the high visibility what is possible. He did that in Illinois. He did that nationally. Certainly, we're both aware of that. I would say if we were to go to a particular disease area that has really made a difference, it's the group that deal with HIV/AIDS. And, this was in the early 1980s, a very stigmatized condition, still is in some ways, but they organized and they tried 1,000 different things. And they had fights within different groups that organized. There were the conservatives and the liberals and the progressives, but they still battered away at it. Now,
Yes.
the big difference that they had was that, a lot of them had their health until they, were close to the last months of their lives, so that they could continue to kind of be advocates. And often that brought them together because, at that time, it was a death sentence. It no longer is, but it brought people together to fight. Now, we have the same numbers. We actually have higher numbers, and we have conditions that are just as debilitating in terms of quality of life, if not more. So we have the same conditions. And I think the biggest difference that we have, if I can be honest with you, is that in this area, because having ME/CFS is so stigmatizing and is such a terrible experience of having the illness, is that when people are able to, they get away and they just want nothing to do with the movement because it's been so punishing, involving their reaction to the illness. So if they have ME/CFS and they have another condition, they'll basically talk about the other condition. It's like being a leper. You are basically in the most stigmatized condition that can occur. Why? Because we believe in the Protestant work ethic, and we believe in energy, and we believe that you have to do it. And if you can't have the energy to basically make it on your own in this country, you are in big trouble.
Right. Yeah, and around that, Lenny, there's within the field of community psychology, there's things like social stratification and different income inequalities that are tied in with ME/CFS, right?
Well, I mean, once you have a condition that is so devastating, you lose resources. Some people lose their families. Some people lose their work, lose their income sources, lose everything. And then if they don't have the advantage of having a family or some resources that they've saved for by good fortune, they're in a really tough situation. So yes, we have a, and there's the other issue is that, if you have cancer or MS, you've got, many programs you can go to where you can get treated. Well, tell me how many ME/CFS centers there are. There really are very few, and that's not good. And if you try to get into some of these high prestige settings, there's wait lists of months, sometimes years. So
yes,
the reality is, this is the people who have this illness are disenfranchised. The people who have this illness are poor. The people who have this illness are angry. The people who have this illness have been discriminated upon. People in this group are often people of color, although that's not talked about. There are so many risk factors for this group that it is a shame the way our nation and the world treats people with this condition.
yes. All right. Lastly, Lenny, one area that I wanted to cover, I know that you mentioned that unless action is taken, history has a way of repeating itself. So I wanted to bring up the latest news with the CDC, and it's positive in a sense because they announced that they're not going to pursue the ME/CFS treatment guidelines from the Pacific Northwest Center for Evidence at this moment. And to paraphrase Viral Disease Branch Chief, Dr. Beth Unger. She said that systematic review provided little new data, and the process for guideline development would not likely advance over what is currently available from the MECFS Clinician Coalition, with guideline developments until more clinical trials are available. A lot of individuals are optimistic, cautiously optimistic. Is there anything that we can do as peers to collaborate with government and health professionals like yourself to make sure that such a thing doesn't happen in the future?
Well, you can sort of ask how much money was spent on that particular report, and did it add anything to the prior report? So if history repeats itself, there you go. You know, where are we spending the money? Look at the money. Look how it's being spent. And I think that is often kind of very valuable. And do we end up repeating things as opposed to taking new directions? Now, I've, in my very short conversation with you, talked about 6 or 7 different directions that I think we could be taking, that we should be taking. And that's the hope, that we can get people united to basically be focusing on the things that can make a difference.
Yes. And as peers, what are some ways that we can create opportunities to open doors with perhaps the CDC and having more of a direct democracy, if such a thing is possible?
Well, you know, I do believe in democracy. You know, it's really, our country and the people that were in this country before we arrived in 1992 had elements of this, and it goes back to the Greeks and democracy. So yes, you know, there should be a way of us basically determining what needs to be done by us banding together. And I do think that if we had the right leadership from the organizations that are currently working with us, they would see that there are 3 things that need to be done, and that all efforts should be focused on those 3 things. And I think that would make a big difference if we could get a consensus on the most high priority things. And by the way, if some group wanted to do a poll, these were the things that would come out. So as a scientist, I usually say collect the data, but I know that this is what's important from all the hundreds of articles I've read and from what I've done with my own research. You know, number 1, we need to have treatment for people who are sick, very sick, and it needs to be geographically distributed. It can't just be in one center that you have to fly into and then you have to go back to. It has to be available. The fact that it's not available is disgrace. That has to be solved, and that has not been solved. Number 2, I think it's critically important for there to be the adequate funding available to enhance, basic research that we need to be done. And the long haul research, I think, is going to be terrific, but we also need research on MECFS in the long haulers. So I think that's critical. And number 3, I think the foundations of everything I'm talking about are something that's so simple to accomplish. And that is for us to get a consensus on who has this illness and who doesn't, and what different variations of the illness are, which might be subtypes. And if we could solve that problem with a consensus in the United States, the world would follow. And that, to me, is the missing urgency agenda that for some reason we have not been able to get people to understand how it connects to everything we do. those would be the three things that I would say need to be focused on. And if we were to do that, we would make tremendous progress, because unexplained illnesses like ME/CFS and the long haulers who don't have something very prominent wrong with one of their organ systems, that is the future of medicine. Because fixing a broken bone, we know how to do that. Basically, many different types of ailments we're able to control. What we don't understand is basically so much of medicine is dealing with unexplained illnesses. 80% of lower back pain is unexplained. If we could better understand what is going on with these unexplained illnesses, ME/CFS could be the fulcrum to basically making major breakthroughs in medicine.
Yes.
If they basically invested the resources in this particular area, we would basically be bringing medicine into the 21st century.
Yes. Well, Mr. Jason, I really appreciate your time. I believe that you're a maverick in your field. There's not too many in this country that do the specific type of work that you do. And I hope that we're able to connect again and perhaps have a peer support group once a month or once in a while.
Good, David, and thank you for very good questions that you asked me and giving me this opportunity to share some of my thoughts. And I hope that the people that listen to this from your group find this of some use. So thank you, David.
All right. Thank you, Lenny.
Okay, bye-bye now.
Bye.